Hi, my name is Dr. Kudzai Dombo, and I'm a board-certified obstetrician gynecologist. I have been working for the last almost 20 years, and I've had the privilege and opportunity of not only being able to work here in the United States, but also work in countries like El Salvador, Sri Lanka, Cambodia, South Africa. And it's just been such an honor to see the different ways that women process their health, their care, the different ways that they try to navigate natural versus, managing the healthcare system. And I have loved every aspect of my career, especially the times that I've ended up needing to pivot so that I could still remain fulfilled in what I do. Because whether or not it was burnout, in the medical system as it exists here in the United States, I've always found a way to reclaim the passion that I have in caring for women. I am excited about this new chapter in my career where I get to bring the experience that I have to Akasha. And I would like to welcome you for a 10-minute information meet and greet session where we get to look at whether or not we're a good fit for each other, right? So there are certain conditions that women encounter that are best managed prior to them requiring hospitalization. I've seen several instances where patients may have had these irregular bleeding, menstrual irregularities, long periods, very heavy periods, and then require admission to the hospital, blood transfusion, and some IV medications to control the bleeding. There are many interventions that we can engage in prior to it becoming that. So I tell patients all the time, if you find that between 3 to 6 months, your periods start to change, become different, become prolonged, or, really heavy, there are things that we can look into to avoid the scenario where you end up in a hospital or requiring like IV management to take care of severe anemia, which can occur if you have menstrual irregularities, if you have fibroids, if you have even conditions like what we call endometrial hyperplasia. These things can be diagnosed in the office with an in-office endometrial biopsy, which is what I do perform, placing a Mirena IUD. So if your biopsy is negative and you have these erratic, irregular periods, we can actually place what's called a Mirena IUD, which has progesterone hormone in it, and it ultimately lightens your periods. Other conditions that I've encountered during my travels, as well as here in the United States, are polycystic ovarian syndrome. And this is a condition where some women actually may go months without having a period. And again, it can be because the body, especially the ovaries, start to produce higher androgen levels, which one of the androgens is testosterone. And when the ovary starts producing higher androgens, it can impact your ability to ovulate. So what can happen is you can either go months without a period, or you may skip 2 months, or you may skip a month, but ultimately it's because you're not ovulating. And then when you actually do have a bleed, it can be a very prolonged, heavy bleed. So again, this is something that really balancing out your hormones is something that we can do to make sure that your body is, or ensure that your body is operating in a way that allows for optimal health. Because with polycystic ovarian syndrome, it puts you at risk for cardiometabolic syndrome. And that syndrome involves a higher risk of diabetes, a higher risk of hypertension, and also a tendency to have weight gain. And that weight gain is not just in all your areas, it can be around your visceral organs, like the heart, all the abdominal organs. And that also causes a higher risk of heart disease. Other conditions that I'm familiar with treating include perimenopause and menopause, and some of the atypical symptoms with how they present. For example, some patients, not every patient who goes through perimenopause and menopause are the same, and some patients may present with symptoms that may be bothersome, but not necessarily clearly identified by a lot of practitioners. Sometimes restless leg syndrome, itchy ears, dry mouth. These are all symptoms of a lower estrogen level that inhibits production of healthy saliva, and that can result in dry mouth. Another common symptom is dry eye. Some patients can have that in a very severe form, and with severe dry eye, one of the things that can happen is you don't produce healthy tears. And as a result of that, you can have conditions where you feel like you have light sensitivity, a lot of pain. And again, considering that this is something that happens during the hormonal transition, there are things that you can do before to reduce your chances of this happening. For example, using a humidifier to make sure that whenever you're on the screen and using a lot of screen time, you have a humidifier to make sure that your eyes are well hydrated. Taking screen breaks, for example, is another thing where you can make sure that your eyes get the chance to blink and produce healthy tears. It's a very important aspect of managing dry eye, because once it gets severe, you're now limited with not really being able to use contacts and using medication to have to treat that. So there are a lot of different things that can be done prior to these diagnoses that can help reduce your chances of having irreversible changes to the body. Some other symptoms that I am familiar with when it comes to some of the atypical. So some patients complain of like a change in their body odor. And what happens when you're in perimenopause, you can have extreme fluctuations of your hormones. And these extreme fluctuations can lead to a lot of sweating, and a lot of sweating can contribute to body odor. But the other thing is that these extreme fluctuations of estrogen and hormones can also lead to an increase in odor-causing bacteria. So this odor-causing bacteria can be very difficult for a lot of women when they notice that their body odor changes, and it can be very uncomfortable. So again, preparing, what are some things that we can do so that you are fully aware that this is something that's a normal part of the body's transition, and it's not something to be afraid of. Some other things that I can think of, some other conditions when it comes to vaginal itching, burning, discomfort. Those are some symptoms that can occur premenopause, perimenopause, and postmenopause, and have varying diagnoses as a contributing factor. And so again, when these things happen, there's no need to be concerned about, but really it's like, okay, just being able to consider what are some causes, what are some etiologies, and what can I do to reduce my chances of having these symptoms so that they're not a surprise? Because it can be very scary when things happen in our bodies that we don't understand. So one of the reasons I'm so passionate about women's health is because I've not only seen women all over the world have to navigate some of these conditions and experience life-altering scenarios and situations, but I've also gone through, as an OBGYN, have gone through many different situations myself where I had to navigate the health system with my own women's health issues. I'll give an example. There was one time when I was operating on a patient. I was doing a hysterectomy with my partner, and my partner at the time was the primary surgeon and I was assisting. And I remember I'd had really irregular bleeding, really heavy periods. I remember thinking, oh, if I just do this, I just need to get back into, being able to work and do what I need to do. But I remember there was a time where I started to feel really lightheaded. And while I was in a surgery, and thankfully, my partner was with me, and I remember passing out in that surgery while I was on my period. They took me to the emergency room, and I ended up having a blood transfusion because my blood count was so low, but I also had a fibroid. And the location of the fibroid was the most impactful in causing the symptoms that I had. It was on the inner lining of the uterus, and that's where you bleed from every month. And so thankfully, I was able to get in with a specialist at NYU, New York University Hospital at the time. I was on the East Coast, and was able to get first-class care without having to have any kind of a minimally invasive surgery that allowed me to go home that same day, and changed the trajectory for me. So these are things that I think it's so important that as women, especially professional women, sometimes the desire is to keep going and keep going and keep going because we have life things that we need to navigate. But I think it's also important to sometimes stop and take care of ourselves so that we don't end up in situations where we are hospitalized, having blood transfusion, medication that's required to reduce the bleeding in order to get back on track. So that's part of the reason why I feel very passionate about helping women navigate different scenarios that come up in women's health. So, what are the causes of fibroids? Some of the conditions that contribute to fibroids, we say are multifactorial. So, if you look at your family history, if your mom, your aunt had a history of having fibroids, you may be at a higher risk of developing fibroids. Certain things like diet, alcohol consumption. Some literature studies claim race has a factor, but across the board of my career, I've seen fibroids in Caucasian and African American, as well as Hispanic patients across the board. So even though, the literature states that race is a factor, I think things like family history, diet, alcohol intake, some patients who have a higher BMI, like obesity, these are some conditions that have been found to be rife for fibroids to occur. So polycystic ovarian syndrome is a condition that has a very wide spectrum of how it can present. There are patients who will show lab abnormalities, but not everybody who has the diagnosis of polycystic ovarian syndrome will demonstrate abnormalities in the blood. So what is this condition? It's a condition where women encounter higher than normal androgen levels, and androgens are the male hormone. So one androgen that we commonly know is testosterone. So what happens is the levels of androgens are high and interfere with the body's ability for estrogen and progesterone, which are the two main hormones that the ovary produces, to be able to function normally and create a regular menstrual cycle where you ovulate every month. So the androgens interfere with the body's ability to do this. And so what tends to happen is women who have polycystic ovarian syndrome will find that their periods, either they go a few months without a period, they skip months here and there with their period, or they may go for months on end without having a period. And then when they do have an episode of bleeding, what tends to happen is they can either bleed extremely heavy or for a prolonged period of time. And I can go into the biology of this in a one-on-one, visit with a patient. However, so menstrual irregularities are one aspect, of the diagnosis of PCOS. The other aspect that can give us a clue is if we do what's called a transvaginal ultrasound, and that ultrasound looks at the ovaries. And if the ovaries have what's quote unquote called a ring of pearl appearance, where you have multiple small follicles within your ovary, that can also give us a clue as to the clinical picture of polycystic ovarian syndrome. The other part of polycystic ovarian syndrome are some of the symptoms. Some of the symptoms that patients describe, as I mentioned, menstrual irregularities. They can also find that they have excess hair growth, right? So, along the linea alba, which is underneath the belly button, that line, they may notice that they have a male pattern hair growth. They may also notice that they have, like, under their nose, upper lip, or underneath their chin, they may notice that there's excess hair growth around that area. They can have a thickening behind the neck, a darkly pigmented line behind their necks. And that's a part of just the male hormone contributing to that. Acanthosis nigricans is the name of that. So these are all things that we ask about and consider in that diagnosis, but it's not exclusive. And then one of the other things is weight gain. It can be really difficult for patients with PCOS to lose weight, and they can experience pretty consistent and excessive weight gain. So we typically say when it comes to the treatment that is one of the first things that we recommend is weight loss. And there are multiple ways that this can be done, but again, that is the number one thing that we always recommend with PCOS is weight loss being what can contribute to the reversing a lot of the body's maladaptive ways of functioning. The other side, when it comes to PCOS, the thing that's really important is cardiometabolic syndrome, which this is where your body is just at a higher risk of developing diabetes, hypertension, heart disease. So you're just more prone to that when you have polycystic ovarian syndrome. And part of the treatment, including weight loss, really reverses a lot of the cardiometabolic effects that untreated PCOS contributes to. I would love to invite you to a 10-minute meet and greet with Akasha, myself, to determine whether or not we're a good fit. It's really important to me that you can determine whether or not I'm a good fit for you, and I can determine whether or not we're an even match. And so I'm offering a 10-minute meet and greet or info session at Akasha, where you get to ask any questions, and I would love to be able to provide the answers to those questions. I'd love to see you there. So some of the procedures that I perform at Akasha include the Mirena IUD. And you may ask, why would anybody want a Mirena IUD? Well, first and foremost, the Mirena has two functions. It offers a source of contraception, which is birth control. It also helps with really heavy bleeding that patients may experience during their menstrual period. So this heavy bleeding can be a result of hormonal changes, or it can be because of the presence of fibroids, one or the other. Both. Mirena is an option for taking care of reducing the amount of and the volume of bleeding that you have with your menstrual period. So it does two things in one, and it's a very simple in-office procedure that can be done without anesthesia. Another procedure that I perform is called a colposcopy, and this is for anyone who may have a pap that is abnormal. So an abnormal pap, usually the reason why we start out with doing a pap smear is to detect for concerns for cervical cancer. When we do a pap, it's considered a screening test. Once we get evidence of abnormalities on the pap smear, the colposcopy, what it does is it takes a closer look at that cervix to see where are those abnormalities, and we do a biopsy, send that off to see whether or not this is precancer, atypical cells just from HPV, or cancer itself. So the benefit of a colposcopy is just that it's a closer look at the cervix, where we actually get to look at the area that may show some abnormalities, do a biopsy, send that off, and be able to get more definitive results as to why your pap came back abnormal. It also helps guide us in what is next, whether it's just observation, where we have you come back in 6 months for another pap, or whether or not it involves a little bit more a diagnostic procedure to get rid of those abnormal cells. So one of the other in-office procedures that I perform is called an endometrial biopsy. Any patient, any woman who is either premenopausal, perimenopausal, menopausal, or even postmenopausal, who has an irregular bleeding pattern, whether it's from polycystic ovarian syndrome, whether it's from fibroids, whether it's from hormonal issues, it's really important that we consider, if this has been going on for 6 months, where you're having really heavy periods, or your period is lasting for more than 7 days consistently, it's really important that we make sure that that inside lining from which you're bleeding from is normal. Like there's no precancerous or cancerous condition that's contributing to it. It's a very simple in-office procedure where we insert a pipelle, get some tissue, send it off, and there's no need for any specific anesthesia. So one of the topics I encounter with seeing patients that's difficult to discuss for them is pain with intercourse. This is something that a lot of patients may not necessarily understand why it's happening or why it's happening to them. However, the more detail that you can provide when you see someone like me makes it so much easier to be able to pinpoint and target how to help. There are different points during intercourse you can have discomfort. For example, let's say with entry, if you experience excruciating pain with entry versus deep thrust, there are different things that we can look at to determine what may be the cause or why this can be so uncomfortable for you. Things like a history of trauma can be reasons. Vaginal dryness, which can happen after breastfeeding or during perimenopause, can be causes and can be very easily treated with vaginal estrogen. Or with deep thrust, we can look at different things like fibroids, things that are structural abnormalities within your pelvis, like a large cyst, again, or a fibroid. These are all things that can contribute to painful sex. And so it's so important that, you feel comfortable and confident that you are not alone, and that this is something that we can kind of look at and determine what the next best step is for you. So what are some things that you can start to consider before you conceive, before you start to try to get pregnant? It's really important that as an OBGYN, if you have any medical conditions like diabetes, high blood pressure, that those conditions are at their optimal best control. So if you have a history of diabetes, it doesn't mean that you can't conceive. We just want to make sure that your blood sugars are well controlled, because that can impact the formation of the baby's organs as after conception. Same thing with high blood pressure. It's so important. We want to reduce any chances of developing some of the conditions that can occur during pregnancy, like, for example, preeclampsia. So if you have high blood pressure, it's very important that, I work in conjunction with your primary to make sure that before you start to try, your blood pressures are at their optimal control. And if you are on medications, that those medications are safe to take while you are in the first trimester of pregnancy. It's also important to make sure that you are on the correct amount of folate and whatever prenatal vitamin that you choose. So folate is extremely important for the baby's spine, the development of a healthy spine, and reduces any chances of spina bifida. It's also important to make sure that you're on some form of a DHEA or omega, because that's very crucial to baby's brain development. Those are things to start. Usually we say 3 months before you start your plan to get pregnancy. And that way, when you get pregnant, your system has already had a buildup of the folic acid and the DHEA so that the baby can benefit the most from these supplements. Other things that are important, like lifestyle. So reducing the stress in your life is very important to balance out your hormones. Getting adequate sleep is extremely important so that your cortisol levels are controlled and your hormones are functioning optimally for you to ovulate and be able to get pregnant when you do ovulate. And then we also discuss things like timing. When is it the most important time to have sex? And we determine when you ovulate based on the pattern of your last few menstrual periods. And we can then determine optimal timing for intercourse so that we maximize your chances for conceiving. So I want to discuss a little bit about abnormal paps. Okay, a pap smear is a screening test for cervical cancer, which we all know. Similar to a mammogram is a screening test for breast cancer. So whenever a mammogram comes back abnormal, you usually get called in for a targeted biopsy where that abnormality is found. So similar to a mammogram, when you have a pap smear that comes in as abnormal, the next step is to be able to do a targeted biopsy so that we can determine what exactly is going on. So whenever you get an abnormal pap smear, it can be read as one of 4 or 5 things. They can see atypical squamous cells of undetermined significance, low-grade squamous intraepithelial lesion, high-grade intraepithelial lesions. And again, these may sound all like foreign terminology, but basically there's an abnormality that needs to be assessed further. Next step we do after you've had an abnormal pap is bring you in for what's called a colposcopy. The colposcopy is essentially a procedure where we actually take a magnifying glass, take a closer look at the cervix, put a little bit of vinegar on the cervix because the cervix tends to absorb vinegar and highlight where those abnormalities are. And once we see where those abnormal cells are, we're actually able to do targeted biopsies, similar to a mammogram, right? We do targeted biopsies. Those get sent off to the lab. We get the results and they tell us, is this something that we need to be concerned about? You can get frank cancer, which would be the worst case scenario. The best case scenario is that these are just, there's nothing that we see. It could be inflammation. It could be an intraepithelial lesion that is stage 1, stage 2, or stage 3. Stage 3, we consider it precancerous, but there's a huge spectrum of what these abnormalities could be. And based on that diagnosis, we determine what the next best step is. It could be as simple as just having you come back in 6 months for a repeat pap smear, or it could be as far as needing to do a procedure, an in-office procedure on your cervix where we remove those abnormal cells. So I hope this explains things and makes things a little bit understandable when it comes to getting a pap smear and then being called in for a colposcopy if that pap smear turns out negative.